morning, everyone. Welcome back to the second day of the 2021 NPF Fellow Symposium. I hope you all enjoyed the programming yesterday. I think it was terrific, and I think we'll have equally good and interesting presentations today, and hopefully we'll all learn a lot. I did want to remind you that this educational event would not be possible without the support of our sponsors. If I could have the next slide. And just to remind you, AbbVie has been a major sponsor along with Medtronic, Alcresta, Digestive Care, Sagent, and ChiroClean. So again, thank you to our sponsors for allowing this to happen. So today's sessions are gonna cover pancreatic cancer with an interesting point-counterpoint debate, some partnership and research opportunities that you may want to tap into, particularly the fellows. And we'll be hearing from three of our fellows about some interesting and hopefully illustrative cases. We'll start with the topic of pancreatic cancer. And I wanted to welcome the session moderators for that section. It's going to be Dr. Anirban Maitra from University of Texas MD Anderson Cancer Center and Dr. Eileen O'Reilly from Memorial Sloan Kettering Cancer Center. I'm sure it's going to be a terrific session. Welcome to both of you.
Thank you, Chris. On behalf of Eileen and myself, it's a pleasure really to welcome everyone to the session on pancreatic cancer. I think, if I may say so myself, we have a terrific session lined up, and Eileen and I are really excited and looking forward to not only the talks, but most importantly also the panel discussion at the end. So this session is unique in the sense we're going to start off with a debate that will feature Dr. Michael Kim and Dr. O'Reilly debating on sort of both sides of an important topic. That'll be followed by a talk by Dr. Chiorean, and then I will come in and sort of finish off the session with a talk on early detection. And then we'll have our question and answer. So without further ado, it is my pleasure to invite the first speaker of this session, who's actually going to be the one side of our debate this morning, and that is Dr. Michael Kim. Dr. Kim is a surgical oncologist with specific expertise in surgery of the pancreas. He earned his medical degree from the University of North Carolina, Chapel Hill, completed residency in general surgery at University of Tennessee, Memphis, followed by a complex general surgical oncology fellowship at MD Anderson Cancer Center, where he also spent time under the mentorship of Dr. Jason Fleming, working on translational research in pancreatic cancer. We're very lucky to recruit him to the Department of Surgical Oncology as a physician scientist, where he directs a vibrant translational research program. He also leads the pancreatic cyst clinic at MD Anderson. And today he'll be framing one side of the debate: resectable pancreatic cancer, neoadjuvant is a win. Go for it, Mike.
Thanks so much for the introduction and the opportunity to talk today. Clearly, given that resectable is a word within the title, it's a unique perspective that surgeons have in this kind of fight against pancreas cancer. And really, neoadjuvant is a win, and I hope to at least convert some people in the audience today as a surgeon pushing for chemotherapy before surgery. So next slide. So we just started about talking about resectable pancreas cancer. So what does that mean to people who don't spend a lot of time in the OR? Really, it's an ABC approach. So our group has really outlined the anatomy, biology, condition approach to evaluating these patients in the clinic. So really, it's a different way of saying, can it come out, should it come out, or can the patient tolerate it? So the first thing is the condition. If patients can tolerate removal of the operation or of the tumor, then certainly surgery is on the table. And we're in the debate of whether to give surgery up front or to give chemotherapy. The second is, can it come out anatomically? And if that checks out, typically in potentially resectable pancreatic cancer, it's not much of an issue. The big question, if you could go to the next slide, is the biology. Really, should it come out? And this is one that is very treacherous in our field. It's not clear meeting a patient in clinic and just looking at them whether their tumor is super aggressive and will metastasize within weeks to months, or if they have more of an indolent, less aggressive phenotype associated with their tumor. The latter would indicate surgery. The former would not indicate surgery. And we have no great way of distinguishing those two patient populations in 2021. There's no assay, there's no great test we can do. We really just roll the dice, so to speak, taking these patients to the OR without monitoring them in the preoperative setting or giving them chemo to really test the tumor biology. So this is a landmine that all surgeons, medical oncologists, radiation oncologists, everyone is looking to avoid stepping on this. Next slide. And this is the scenario of how that landmine plays out. So a patient comes to us. Of course, it's a great person with kids and a family, and we want to do everything we can for them. And the decision is made to go to the OR. Everyone is on board. We want to save the person. Operation is done. The tumor is out. We look away for 5 months, and then the next scan reveals all these mets everywhere. And we really can't say we've helped the patient. We've put them in the hospital for a week. We've condemned them to difficulty eating and drinking for maybe a month or so, and potentially other complications. But we can't say we've really helped these people. And this is what we want to avoid. Next slide. In the same vein, we know that pancreas cancer by definition is a systemic disease. So everyone pretty much I know thinks about all the tumor cells floating around the body that have colonized the lung, the liver, when we see patients. And we're under no false impression that any patient who presents to us with pancreas cancer doesn't have this going on. This is well substantiated by mouse models and clinical experience. So really, this can, through the lens of a surgeon, be perceived as R1 disease. So R0 resection is what we strive for with curative intent. We want no tumor cell left behind. We want negative margins, no lymph nodes involved. And all the staging efforts we do before surgery are aimed at detecting occult metastatic disease. This hurts our feelings when we take these patients to the operating room and have R1 or microscopic disease on our resection margins or in lymph nodes. It's not something we choose to do. And it really violates a central tenet of pancreas surgery or surgical oncology in general, which is to leave no positive margins behind. But in a way, we kind of assume everyone have R1 or microscopic disease, positive margins when we see them. And to just rush these patients to the OR without doing what we can to mitigate the chance for an R1 resection and promote the chances of an R0 resection is a little bold. Next slide. And so to cut or not to cut, this is again through the lens of a surgeon. We'll get to the data soon, but the pros perceived at least is the tumor is likely to be removed, and we can talk about that. It's probably more of a false sense of we're doing something for the patient immediately rather than we're actually helping the patient. The cons are, of course, the surgical complications, in that only about half of people who go through this process and get upfront surgical resection received chemotherapy on the back end. So what we're saying is we have a microscopic R1 resection, undoubtedly, in the body, and only half of those patients will receive any systemic therapy to address that if we do surgery first. On the neoadjuvant end, we can say that most patients get systemic therapy, not all of them, and we can talk about that a bit downstream. We do, however, treat early the tumor micromets that are there, and we can monitor the biology of the disease. We can figure out, is this a rapid progressor or is this an indolent disease? And we can match the operation to that biology. So if someone is rapidly progressing, those patients probably won't benefit from surgery. We do nothing to help them other than just make ourselves feel better by removing the tumor. And really that's probably all we do. However, if someone has an indolent disease, an indolent phenotype, we probably do help those people. We probably do buy them time and quality of life by doing major pancreas surgery. So definitely perhaps the debatably, this is the best and most useful part of neoadjuvant therapy, is the opportunity to observe and learn tumor biology before we commit patients to complex operations that are fraught with complications and risks. And we are able to select them as such. And the cons of a missed surgical window while we're giving chemotherapy, that's also probably more of a myth than fact, but we'll talk about that in a little bit. Next slide. I wanted to point out something that's not often discussed, which is the true cost of surgery for patients with pancreatic cancer. Pancreas surgery over the years has become much more safe. It's become much better tolerated by patients through a variety of measures that have been taken, increased training of surgeons, increased perioperative care. But we often only look at forest plots and Kaplan-Meier curves when we talk about how people do after resection. It's kind of just blown by at the expense of just looking at overall survival, disease-free survival. We often don't consider the true costs of patients undergoing major pancreatic surgery. So on the left is a New England Journal paper from about 20 years ago from the United States that measures the mortality. So these are patients who die around the time of surgery after major pancreas surgery. And on the low volume centers, it's about 18% of patients die around the time of surgery. At high volume centers, it's around 4%. And these numbers probably are true today in 2021. And just last year, out of Germany, again, a very advanced advanced society with great surgeons and lots of resources, their numbers are about the same, maybe a little bit better. 6% of people die around the time of this operation. And in high volume centers, these are the people doing this every day almost. So these patients are never really talked about. They don't really make it to a lot of the discussion when we talk about potential benefits. There's no free lunch when it comes to this kind of surgery. Next slide. So ideally, we would like to at least observe tumor biology to prevent this. And what I'm talking about is if we do upfront surgery, we turn our heads, and then patients have disease progression within the months following surgery. And that is not helping anybody. Patients are really harmed by that. They need systemic therapy at that time, and many times it's within the post-operative recovery time, and they can't get it. So the therapy they need the most, which is not surgery, they can't get. And then whenever we start systemic therapy, many of them won't tolerate it. Again, about 50% of patients receive adjuvant therapy after pancreatectomy. Next slide. The more kind of measured and thoughtful approach, at least in my opinion, is kind of neoadjuvant therapy approach, where we stage the patient, we treat them with chemotherapy, sometimes radiation, we restage them, we observe tumor biology, we figure out, are they rapid progressors, are they indolent progressors, and then we match the operation to the biology of each patient, because we otherwise have no idea about the biology of each patient's tumor. And then, if indicated, we do surgery. Next slide, please. So this is from our group, and I think this was before the era of FOLFIRINOX, but it nonetheless holds true based on other studies out in the field. So how many people progress while getting upfront chemotherapy is the question that is addressed by this slide. So something of a myth is that if we give patients chemotherapy for 2 to 4 months before surgery, well, their disease can progress. And we find that's true for about 15% of patients. It's probably about 20% or less in most of the series that have looked at this, which I would argue is a good thing. So if patients' tumors are progressing on chemotherapy, or they're not able to tolerate the chemotherapy, those are signs, those are signals that we probably shouldn't be doing surgery in those patients. We're going to do a major operation with potential complications or mortality, and what will we get out of that? Patients will recur within months, likely. Likewise, if they're not healthy enough to tolerate the operation, if they can't tolerate chemotherapy, they're probably not going to do much better with a major surgical resection. So those patients are selected out against, and again, we don't match surgery with those patients. We match chemotherapy with those patients, radiation with those patients. Surgery is not likely to benefit. Next slide, please. So now we're starting to see some signals. So, and this is a propensity score match analysis by our colleagues at UT Southwestern involving about 15,000 patients. So they looked at a 3-to-1 ratio of people who received upfront resection versus neoadjuvant chemotherapy, and found that that improved survival was really associated with the administration of neoadjuvant chemotherapy. This is a signal. Obviously, it's retrospective, not randomized, but this is a nice signal in 15,000 patients that neoadjuvant therapy, instead of upfront resection, is beneficial to patients. The other thing that come out of the study is pathology. So when the specimens of these patients who underwent resection after neoadjuvant chemotherapy, we saw significantly less positive resection margins and lymph nodes, which really tells us that neoadjuvant chemotherapy is hitting that occult disease. It is killing tumor cells and tumor cell clusters, not only in the pancreas, but likely also in the liver, lungs, wherever else they might be harbored. And I think that is really what patients need for this, to prevent this R1 resection. Next slide, please. This is a nice study, perhaps one of the strongest that would support neoadjuvant chemotherapy. It was a Dutch study, the PREOPANC trial. This is what everyone talks about, where patients were given 2 cycles of pre-op gemcitabine, followed by gem XRT and more gemcitabine versus surgery with 6 cycles of adjuvant gemcitabine. And so one could say, well, we're past the era of gemcitabine, more towards FOLFIRINOX, and that's very true. On the intention to treat analysis, there was some significant differences, specifically in local regional recurrence-free interval, as well as disease distant metastasis-free survival. However, overall survival was not significant, and the p-value was close, but it was definitely a trend. You can see that all of these survival curves definitely have a trend towards benefit in the preoperative chemoradiation trial. This is the intention to treat on the patients who actually received resection. All of these curves became significant. And that's really the reality we're talking about. It's nice to have nice randomized data, but at the end of the day, people fall out of the data set for many reasons. And we're really looking for patients who actually will go from start to finish. And when we get a really clear signal on that end and indications of trends and signals on the front end, on the intention to treat, I think this is really strong evidence that neoadjuvant chemotherapy favors the patients with resectable pancreatic cancer. Next slide, please. This is another great trial out of Japan, where they used S1, which is not really used in the United States, but nonetheless generates proof of concept, at least in the Asian population, where patients receive neoadjuvant gemcitabine and S1, then surgery, then adjuvant therapy, versus just surgery versus adjuvant therapy. This is significant because in phase 2 part of this trial, patients on the neoadjuvant therapy arm underwent resection at approximately the same rate as people who had upfront surgery. So kind of the myth that neoadjuvant chemotherapy really allows a window for disease progression. I think there's some truth to that, but at least in this study, actually more patients got resection in the neoadjuvant therapy arm than the upfront surgery arm. Not statistically different, but there was no difference there. There's no lost window. And next slide. We can see that there was a significant survival benefit of 10 months, and that's getting to the point where it's really worth putting these patients through these major operations. There are no differences in morbidity. Again, we had less pathologic lymph nodes. Patients overall seem to do pretty well. We had less hepatic recurrence. Again, this is another signal that systemic therapy is killing all that occult tumor. and maybe maximizing the chances for an R0 resection, which, again, is the goal of every surgeon, in reducing the chances of an R1 resection, if even that R1 disease is in the liver, lungs, places we're not looking at them through the microscope. So I think this is a very robust study that shows neoadjuvant chemotherapy is doing something to treat occult disease. It is allowing for equivalent opportunity for surgical resection. We're not necessarily giving up a window for resection, and we're really can help patients through this approach. Next slide, please. So conclusion, pancreas surgery is fraught with risk. I think this is an underappreciated aspect of all of these studies. People don't do well with major operations when they have progressive disease or they're deconditioned. And we really need to make sure that the ends, overall survival, recurrence-free survival, really justify biting off these major operations that, quite honestly, as surgeons, we see and we nurse these patients back to health, sometimes hand in hand. Pancreas cancer is a systemic disease with unpredictable biology. Perhaps the most beneficial aspect of neoadjuvant therapy is understanding this biology. We do not want to play whack-a-mole in patients. We don't want to go and take their primary tumor out only to have them develop metastatic disease within months. Those patients we're not helping, and those patients can get systemic therapy and enjoy the time they have left rather than spend that time in the hospital or recovering from our operations. There are great, strong signals of survival benefits associated with neoadjuvant chemotherapy and radiation therapy, and those will continue to develop in the coming years, and I look forward to that. And really using more modern treatment regimens, I think we'll really learn how to optimize neoadjuvant chemotherapy to extend survival and recurrence-free survival. So I'll end with that. I appreciate the opportunity to make these points through the lens of a surgeon, and I look forward to the rebuttal.
Thank you, Mike. So just a reminder, we're going to be holding questions to the end, but please type in your questions in the Q&A box, or during the live session. You're also welcome to raise your hand and ask a question live. You can upvote the questions that are in the Q&A box so that Dr. O'Reilly and I will pick the ones that appear to be audience favorites. So now let's reframe the other side of the debate, and it's a real privilege to welcome Dr. Eileen O'Reilly. She's the Winthrop Rockefeller Endowed Chair in Medical Oncology, co-director of the medical initiatives at the David Rubenstein Center for Pancreatic Cancer Research, and the section head for hepatobiliary hepatopancreatobiliary and neuroendocrine cancers. Dr. O'Reilly's research initiatives include integration of molecular-based therapies for the treatment of pancreas cancer. And in particular, as you well know, she co-led the POLO trial, which is the first ever therapy approved specifically for pancreatic cancer with a known molecular alteration. And so we're very excited to hear her side of the debate now. Resectable pancreatic cancer, proof of evidence is adjuvant, and there is an exclamation mark at the end.
Well, good morning, everybody. Thank you, Anirban, for the introduction, and thank you to the NPF for the invitation today. It's really a pleasure to be here. Yes, indeed. So the topic is resectable pancreas cancer and advocating in favor of adjuvant. And I just want you to notice that you had a surgeon speak against upfront surgery and even oncologist advocating for initial surgery and adjuvant therapy. So I think that's as fair as you can get in terms of perhaps arguing a counterpoint. So I'm just acknowledging here various research disclosures and funding. I do a lot of drug development in pancreas cancer. Next slide, please. So just going to start a little bit about the biology and just pick up on some of the themes that Dr. Kim discussed. And just this is a spectrum, and at the extremes, resectable and locally advanced disease are easy to identify. And I think at the extremes, the treatment paradigm is straightforward, but this is a continuum in terms of how the disease looks, from resectable with clear margin around the tumor to where in unresectable disease, you see vascular encasement. Next slide, please. And just thinking a little bit about the biology of pancreas cancer, it is indeed a systemic disease, and we knew that's true for a majority. However, autopsy series have informed that there is a subset of patients who have local-only disease, i.e. present with local-only disease and never metastasize or recur with local-only disease following resection, suggesting that all modalities, both systemic and local approaches, are essential here to maximize outcomes. Next slide, please. And looking at just the patterns of failure after surgery gives us the setting that there are different subsets of people with pancreas cancer. And I just want to bring this up because that may not be so apparent to the audience, that liver metastasis is in general a poor prognostic setting, and liver metastases tend to occur early after surgery, whereas lung metastases tend to have a more biologic indolence and tend to have later recurrence. And these patients can often benefit from local therapies as well as systemic therapies where they recur over time. And we see quite a divergence in terms of outcome. Next slide, please. And so the key issue here for resectable pancreas cancer is that you need the ability to do an optimal resection, and you need the ability to deliver the most effective systemic therapy. And there really isn't any debate about that. It's not one modality versus the other, it's both. I think the question that we're debating here is what's the best timing of these modalities, not whether they should be both included or not. And we certainly see the best outcomes for patients who've been able to receive both systemic therapy and surgery. We're not really going to address the radiation question, which is a thorny aspect in this disease subset. Next slide, please. So here's the only randomized trial that's been done in pancreas cancer, whether or not surgery should be conducted. And this was a small Japanese study that was a statistically significant positive trial. And you'll notice Dr. Kim didn't present a lot of positive data. He presented the PREAPANC study, which is actually a negative trial. And he also presented a study from Asia, which utilizes a drug that we don't have available in the US. So we can argue that those trials we can sort of discount. And I'm going to provide you with some evidence that would support why adjuvant therapy is first. Next slide, please. So we've looked at this, and just the paradigms, of course, are the rationale for early delivery of systemic therapy. And that's a key goal, to get a person safely through surgery to recover and to be able to commence adjuvant therapy in a timely way. And Dr. Kim has kind of reviewed this, but there are lots of rationales in both directions. Next slide, please. And so next slide, please. And speaking to the data here, just going to give you a brief rundown on the trials that support why adjuvant therapy is the go-to strategy. This is the original CONCO 001 study that compared gemcitabine to observation. Next slide. And this was recently updated in terms of long-term outcome. Next slide, please. And you'll see that there is a statistically significant, next slide, thank you. Seems to be a little bit of delay here. Are the slides stuck? Thank you. Here we go. So the original study reported a positive disease-free survival advantage, which was the primary endpoint. And if you look at long-term outcomes, you'll see about double the number of patients who were alive at 5 and 10 years who received adjuvant therapy following surgery compared to observation. Next slide, please. So a subsequent step, and I'm just kind of highlighting the key studies, was to add a fluoropyrimidine to gemcitabine. Gemcitabine worked in the adjuvant setting, 5FU worked in the adjuvant setting. So now how about combining both together and comparing to gemcitabine on its own? Next slide, please. And this was also a positive study, a hazard ratio of 0.82 and an improvement in median overall survival, 28 versus 25 months. This was recently reported, and up until a couple of years ago was the standard of care in the post-operative setting. And if you'll move to the next slide, please. This supports the highest level of evidence we have in favor of adjuvant therapy. This is the PRODIGE 24 trial, which compares FOLFIRINOX, 5-FU, oxaliplatin, irinotecan, and leucovorin compared to gemcitabine on its own in the adjuvant setting. I will acknowledge that this was a selected patient group, had to be able to recover from surgery, had to have a CA99 less than 180 and have a good functional status post-operatively. Next slide, please. The primary endpoint was disease-free survival. And if you look at this, there was a clear difference in disease-free survival, about an 80% improvement in disease-free survival, improving from 12.8 to 21.6 months, which is compelling. And if you go to the next slide, please, this is really what got people's attention and enthusiasm, is the overall survival. And you'll see here a median overall survival of 54 months compared to 35 months, which is clearly statistically significant with a hazard ratio of 0.64, and is a strong argument for a fit patient in favor of surgery first, followed by this standard of care. Now, this is a toxic regimen, and it does require dose reductions and sometimes treatment delays, but nonetheless, being able to administer this in the post-op setting provides the best outcome that we have. So next slide, please. So just to give you a summary, again, we're not going to go through all the details, but to say that overall survival has been steadily improving in the post-op setting, related in part to treatment and improvements in treatment, but not exclusively to that. And this is just for your reference. Next slide, please. We have some data pending on adjuvant therapy. We're waiting for a large randomized study evaluating chemoradiation in the adjuvant setting that will read out probably in 2022. We have a similar trial to the one we've just looked at, which evaluates FOLFOXIRI, slightly different dosing regimen of irinotecan and dose of 5-FU. And then there's an interesting study from Germany looking at hyperthermic therapy in the post-op setting. Next slide, please. So these are the factors that contribute to outcome. And Dr. Kim mentioned it, and I'll endorse this. It's patient selection. And I think at the end of the day, it's not going to be one size fits all. It's all about selecting the right therapy for the right patient. I think limiting CA99 better selects patients. We have improvements in supportive care. So we know how to give these regimens. We know how to deliver them safely. And the therapy, of course, is added to outcome. Next slide. Next slide, please. So a problem, though, is our ability to deliver treatment in the post-operative setting. You'll see that these rates are not so high, and that admittedly is an argument in terms of perioperative or preoperative delivery. Next slide. And sorry, I'm going to go one more slide. Next slide, please. Yes, so this one is just to give you some reference data of what perioperative therapy looks like in the current era. This was a SWOG trial that Dr. Chiorean, who's on the panel, will be speaking in a few minutes in novel therapies. But she was, and the team were part of this, which looked at our two favorite regimens in the perioperative setting. And if you go to the next slide, and this is in resectable pancreas cancer. This is the current era North American study. And you'll see here the median overall survival is 2 years. And just to note that neither regimen fared as well as the pre-planned statistical analysis. The study wasn't designed to compare both, but is compared to historical controls. And you'll keep 22 months median overall survival in mind compared to 54 months for the adjuvant study. Now, admittedly, it's not like to like because the clock is starting at a different time point. But just again, to illustrate, it's not a slam dunk here in terms of one approach, and certainly not a slam dunk in terms of neoadjuvant. Next slide, please. This is a study, this is a national trial being led by the Alliance Cooperative Group, which is trying to address what we all want the answer to, is what's the best approach. And it looks at current modified FOLFIRINOX regimen with surgery spaced in between, or upfront surgery and adjuvant therapy. And this study is about 10% accrued, and we'll look forward to seeing this mature out. Next slide. So we're waiting some additional data on neoadjuvant therapy. And again, just to emphasize, we don't have a lot of high-level data in this space, so we really have no positive randomized trial in the Western world supporting neoadjuvant therapy in 2021. Next slide. So summing up here, again, no one right approach for all patients, but I think the clear issue is selection. The main arguments for adjuvant therapy are that the highest level of data supports adjuvant therapy. Main arguments for neoadjuvant are using treatment, biology, and time as selection factors. So if you go to the next slide, please. I would say right now, the evidence, and if we're sticking to evidence, and this is an evidence-based debate, is in favor of surgery first and adjuvant. Next slide. But there are clearly circumstances, as Dr. Kim nicely alluded to, where we don't want to recommend initial surgery for a patient who has comorbidities, large tumor, elevated CA19-9, etc. That would all sway the deck in favor of a neoadjuvant approach. But in counterpoint, for a fit patient with a small tumor, clear negative margins, who we know can safely get through surgery, has a low CA19-9, and maybe doesn't have a tissue diagnosis, I think it's hard to argue with taking that patient to surgery. Next slide, please. So thank you very much. I'll stop there and pass it back to Dr. Maitra.
Thank you. That was a fabulous framing of the debate between Drs. Kim and O'Reilly. And again, please remember to put questions in the Q&A box and upvote the ones you like so we can prioritize them. So I think we'll now move to the second half. No more debates, straight up talks. So I'll now pass the baton to Dr. O'Reilly to chair the remaining part of the session.
Great. So thank you very much, Anirban. We should have had a poll here for this debate, just to add some spice to it. So it's a real pleasure to introduce Dr. Gabriela Chiorean, who's a professor at the University of Washington. She's an authority in pancreas cancer, has done a lot of drug development, has many national roles in the Pancreas Task Force as vice chair in the GI Steering Committee, and is a wonderful colleague and friend. And she is going to introduce the topic of where the field is with regard to novel therapies in pancreas cancer. Gabby, thank you very much for being here today.
Thank you so much, Eileen, Anirban, and National Pancreas Foundation for having me. Next slide. I'm going to talk today about overseeing the pancreatic cancer genetic evolution and really looking at some of the major targets that are really developing our next generation of treatments for this disease. And we wouldn't have seen this coming even 5 years ago. A lot of this work has been done by Dr. O'Reilly, and I want to thank her for her tremendous contributions to the field. There is not one paper that I open without seeing her name. So these are some of the novel therapies that I'm going to talk about today, from DNA damage repair to the MSI tumor mutational burden high pancreatic cancers. Something about KRAS mutations. We used to think that KRAS is an untargetable alteration. And also there are 6 to 8% of our patients that have KRAS wild type gene status that opens the door to some other potential targets. We're gonna also mention the tumor microenvironment, including the immune microenvironment, and a little bit about the cancer metabolism. Next slide. The pancreatic cancer genetic progression model, we used to think that this is a type of cancer that grows very fast And we recently learned that it can take up to 10 years from a precancerous to a cancerous, an advanced cancer lesion to develop. We do see here in this noteworthy paper that many oncogenes in green are activated in the course of the disease oncogenesis, and many tumor suppressor genes lose their function, such as those depicted in this slide. Next slide. The landscape of metastatic advanced pancreatic cancer treatment had started more than 20 years ago with gemcitabine. We introduced an epidermal growth factor receptor tyrosine kinase inhibitor with very minimal benefit in 2005. And then it's really been taken by chemotherapy, multi-agent chemotherapies for FOLFIRINOX and gemcitabine with nab-paclitaxel. Until you've heard recently about the POLO study, which was really enrolling patients with germline mutated BRCA1 and 2 mutations, which showed that olaparib has a role for certain patients in a maintenance setting after chemotherapy. In the second line setting, we have several targeted agents, including immunotherapeutics, but also the nanoliposomal irinotecan, which has been on the agenda since 2015. We have pembrolizumab, approved by the FDA for MSI high or even TMB high cancers, as well as two agents, larotrectinib and entrectinib, for patients that have tumors with NTRK 1, 2, or 3 fusions. Next slide. The genomic sequencing in pancreatic cancers, initially in xenograft models and then in pancreatic cancer tissues, have really stirred the momentum in studying targeted therapeutics for this disease. And we do see really a plethora of pathways that are altered, including TGF-beta, KRAS, cell cycle apoptosis, DNA damage, and many others. And I would say that many groups are researching ways of targeting all of these pathways, and even in combination approaches. Next slide. This was a POLO study with, which really tested more than 3,000 patients to identify approximately 150, which were treated initially with platinum chemotherapy for at least 4 to 6 months. And patients that had no evidence of progression, therefore were platinum sensitive, were offered the option of a maintenance therapy without chemotherapy, which was a placebo or a PARP inhibitor, olaparib. The FDA approved olaparib for this purpose in 2019, based on this landmark study published in the New England Journal in 2019. And you observe about a 4 months benefit in progression-free survival by olaparib versus placebo. This study was criticized slightly due to the fact that patients were not offered a continuation of chemotherapy and rather were exposed to a placebo in the placebo control arm. Next slide. Talia Golan and colleagues updated the overall survival for the study at the 2021 ASCO GI Symposium, and unfortunately there was no significant benefit in overall survival with olaparib versus placebo. Suffice it to say that the placebo arm patients, many of them had access to PARP inhibitors upon progression, which could have affected, of course, the overall survival data. Nevertheless, many patients treated with olaparib obtained partial or complete responses and were able to remain in remission for many years. Next slide. PARP inhibitors in germline BRCA1 or 2 mutated pancreas cancer patients do have modest benefit compared to the same agents used in ovarian or breast cancer. And we are yet to discover what are the reasons for the modest activity in pancreas cancer, and maybe what biomarkers select patients more likely to respond. We know that there are reversal mutations that occur in pancreas cancer. We know that there are multiple pathways that are activated that may actually hinder benefit from PARP inhibitor. So response rates are anywhere from 0 to 20% with single agent PARP inhibitors in patients with refractory disease. Next slide. Where the data is even more striking, I would say, is that patients with germline BRCA1 and 2 mutations and also PALB2 mutations, and more recently, we also observed this, maybe the same benefits in patients that have somatic BRCA mutations, is the sensitivity to platinum chemotherapies. Dr. O'Reilly published a landmark paper in JCO 2020 showing that gemcitabine with cisplatin chemotherapy, with or without veliparib, results in response rates as high as 70% and overall survival rates in around 16 months, comparing with the historical controls of about 9 to 11 months with a standard chemotherapy for patients without BRCA mutations or unknown BRCA mutations. Several other publications highlight that patients that have these homologous recombination deficiencies may actually benefit more from platinum chemotherapies and have superior survivals comparing with other non-platinum chemotherapy therapies. Next slide. MSI high is another biomarker that is a standard of care to be tested for all patients, any stage of pancreatic cancer, by germline testing, and for those with advanced disease, by somatic tumor biopsy profiling. This is the first paper by Yang Li that showed that pembrolizumab has a significant response rate, or more than 50%, in the few patients with pancreas cancer that were found in this study to be MSI high. Next slide. An update and larger study that was published by Marabel in 2020 showed that pancreatic cancer patients to the left that had MSI high status and were treated with single agent pembro had response rates that were a little bit more modest, of only 18% among the 22 patients that were recruited. It is possible that the way we test MSI high may be different from site to site, and not all cancers that are labeled MSI high may be truly high on a next generation sequencing testing. In a subsequent paper, Marabel also published for solid cancers that had TMB high, defined as more than 10 mutations per megabase, among 100 cancers, but none of them were pancreatic cancers. Response rates were high with pembrolizumab, about 30%, and the FDA approved pembro for such cases. Again, it is worth testing TMB status in pancreas cancer, but we do know that typically pancreatic cancer has TMB burden of less than 6 mutations per megabase. Next slide. KRAS is really one of the most important genetic alterations in pancreas cancer. It occurs in more than 90% of pancreatic ductal adenocarcinomas. There are many types of KRAS mutations. One of them, KRAS G12C, relatively rare in maybe 1 or 3% of cancers, has resulted in a targeted therapeutic, Amgen 510 or sotorasib, which had proven responses as well as prolonged stable diseases in some patients. There is still a lot of work to be done to optimize the efficacy from KRAS G12C targeting. KRAS G12R is another mutation that occurs in about 15 to 20% of patients that has shown potential benefit from MEK inhibitors in some observational studies. Next slide. This is just a recent presentation at ASCO GI by our group at University of Washington, showing that patients that have KRAS G12R variants have superior survival comparing with other KRAS G12R mutations, but the survival advantage is abrogated by concurrent alterations in the PI3 kinase pathway. This really invites further studies to determine how best to target this signaling pathway. Next slide. One of the most significant progress in targeting KRAS comes from investigations in targeting the KRAS-SOS1 interaction. As you see in this panel, SOS1 is really a guanine transfer enzyme, which really enables the activation of KRAS and the transfer from RAS-GDP to RAS-GTP with further activation of the MEK-ERK pathway. There is a feedback mechanism between ERK and SOS1, and therefore it's expected that SOS1 targeting may be superior and synergistic with MEK or ERK inhibition. Clinical trials with this therapeutic agent are ongoing, and we expect to see more in all subtypes of KRAS alterations. Next slide. The KRAS wild-type subset is enriched with several genetic mutations and fusions, such as NTRK, ROS, ALK, and we have benefit from agents such as larotrectinib on the left and entrectinib in the middle, as well as cediranib targeting ALK on the right panel. There are also other genetic alterations, including HER2 amplifications, BRAF mutations that are enriched in this subset, and therefore worth of submitting next-gen sequencing or at least targeted sequencing profiles for these particular genes. Next slide. NRG1 fusions are also a topic of high interest. This refers to the ligand for the HER2, HER3, and zenocutuzumab, as well as afatinib, had been tested in patients with exhibiting NRG1 fusions in their tumors with substantial benefit. There is an ongoing phase 2 study with zenocutuzumab targeting patients with NRG1 fused tumors. Next slide. Match therapy for patients that have underlying targetable alterations. If they are offered match therapies, overall survival, as shown here in a PanCan registry publication by Mike Bishwayan, shows significant superiority with doubling of overall survival, pointing to the need of sequencing our patients' tumors and germline status, and really offering the best available therapies, whether available and on the market or in clinical trials. Next slide. This is just a summary slide for you for the available alterations and clinical trials available with these respective therapies. Next slide. Regarding microenvironment, I'm going to talk about a few agents that are in clinical trials or have shown promise to date. Next slide. Targeting PD-1 and CTLA-4 has shown substantial benefit in melanomas and other cancers, maybe not so much to date in pancreatic cancer. To the left, we have a publication by Zainberg and others with gemcitabine nab-paclitaxel and nivolumab. In the middle, we have durvalumab tremelimumab with gemcitabine and nab-paclitaxel, showing no benefit from the addition of combination immune checkpoint inhibitors. And to the right, we have again durvalumab plus minus tremi, unfortunately with no substantial benefit. Next slide. Interesting data comes from a CD40 agonist, which we know activates the antigen-presenting cells and may also shift the M2 macrophages into tumor-fighting M1 macrophages. This is the apexigen agent, with or without nivolumab and chemotherapy, gemcitabine nab-paclitaxel, showing response rates upwards of 50% in a recent publication. This study is, again, showing the ability of synergistic immune therapy combinations that we hope to see more of in randomized clinical trials against the control arm. Next slide. Another target that is important in pancreatic cancer that we hope will pan out in future randomized studies is CXCL12 and the respective receptor CXCR4 blockade, which really enables the infiltration of cytotoxic T cells and helper T cells inside the tumor. CXCR4 BL8040 agent, moxeparvovec, in combination with pembrolizumab, had shown benefit in pancreatic cancer, both as a combination immunotherapy as well as with the Napoli regimen, the liposomal irinotecan with 5-FU. What you see here is on the left, responses in liver metastases, and on the right, the increased rate of helper T cells, CD4, CD8 T cells in the tumor on study comparing with the baseline concentrations. The response rates with chemotherapy were in the order of 20%, and these are clearly superior comparing with the historical data of approximately 5 to 10%. Next slide. CD73 is another molecule that really affects the inhibitory pathway, the adenosine pathway in the microenvironment. Several companies have agents targeting CD73, such as AB680, oleclumab, and others. This is just a small pilot study that was presented at ASCO GI 2021, showing response rates of about 40% with AB680, PD-1 inhibition, and chemotherapy. Next slide. SEND1 is another novel agent that had shown response rates of 60% in combination with gemcitabine and nab-paclitaxel. The way this agent works is by targeting integrins and allowing the diffusion of chemotherapeutics through the endothelium inside the tumor. This agent, this IRGD peptide, which unlocks the stroma, may enable benefit, including from antibodies and immune therapeutics. And we are hoping to see more of this drug developing in pancreatic cancer. Next slide. Last but not least, cancer metabolism really relies on glycolysis and persistent mitochondrial pyruvate dehydrogenase activity. Cancer cells also depend on glutamine and asparagine, and several clinical trials are targeting the mitochondrial metabolism, and the asparaginase through eriaspase has shown in the bottom right a significant benefit in overall survival when combined with chemotherapy. These agents are currently undergoing or have just completed phase 3 clinical trials with chemotherapy and are awaiting hopefully positive results. Next. In conclusion, going back to this beautiful review paper by Dr. O'Reilly and a co-author in Seminars on Oncology, we have here several therapeutic targets in pancreatic cancer and a lot of reasons to be optimistic that either single agents or more likely combination approaches will be successful in this disease. Thank you. And just not to forget, we're looking up to you, to the new generations of scientists to develop novel therapeutics and to improve the survival in this dreadful disease. Thank you so much.
Great. Well, thank you very much, Gabby. That was terrific, a really thorough overview of what's happening. And I think this is where the excitement in pancreas cancer, this area, and the one that Dr. Maitra is going to talk about in a moment. So thank you very much. So once more, it's a pleasure here to introduce our next speaker, Dr. Anirban Maitra, who's a professor of pathology and translational molecular pathology at UTMD Anderson. And he is the scientific director of the Sheikh Ahmed Pancreatic Cancer Research Center at MD Anderson. He's extremely widely known, very well funded, and has multiple areas of expertise in pancreas cancer with an increasing focus on early detection, such an important area. And I'll also just mention one other thing, that if you want to know what's happening in the pancreas cancer world, please follow Dr. Maitra on Twitter. That's where I learn all of what's happening, all the new papers. You're always so thoughtful and great insights into the field. So Anirban, it's a delight to have you here, and thank you very much.
Thank you. Thank you, Eileen, for that very kind introduction. It's really a pleasure to co-host this session with you. And thank you to Jane and the NPF for inviting me to speak, hopefully next year in person. But till then, let's do this on Zoom. So I want to talk, I'm going to actually pivot from therapy a little bit, although you will see why the therapeutics we have discussed so far does become important in some respects here, and talk about early detections. Next slide, please. So as we all know, there is a rising burden of pancreatic cancer deaths in the United States, unfortunately, matching the rising incidence. It is currently the third most common cause of cancer-related deaths in the United States. Next, in the state of Texas alone, from 2018 to the current year, if you look at the Texas Cancer Registry data, you can see how the numbers of both cases and deaths have gone up. Next slide. So one thing that really underscores the importance of early detection is when we look at improvements in survival, they're mostly being made in resectable cohorts. If you can click the next arrow, please. These are SEER data. They're a little bit old, and so the numbers have obviously changed, but nonetheless, really amplifying the fact that if you compare the survival in the lowest stage disease, which is stage 1A versus stage 4, that difference is fairly significant. Next. And you can click twice. You can click one more time as well. I'll just go through the whole slide at one go. And again, I'm not debating neoadjuvant versus adjuvant. We've had that debate already by people who are far greater experts than me. The intent of this slide is to basically really underscore the fact that when we talk about long-term survival, and I'm talking here about many months to years, all of those advances have really happened in the context of resectable disease. And whether those patients get neoadjuvant or adjuvant, that is not the context of this slide here. If you look at our MD Anderson data, if you look at the Prodigy trial that Chiorean talked about, all of this, Dr. O'Reilly talked about, all of these advances that have happened in terms of true long-term survival have happened in resectable disease. When I go to symposia or patient advocacy meetings and I meet long-term survivors of pancreatic cancer, almost without fail, they're patients who've been fortunate enough to have been diagnosed at an early stage, gotten the tumor out, and either received neoadjuvant therapy before or adjuvant therapy later. Next slide. And you can actually click 3 times here because we'll just, again, talk about the slide as we go. So if you look at the top here, there are some series from the 90s from the Far East looking at these microscopic tumors in the pancreas that measure less than 1 centimeter. They tend to be a little bit more aggressive in Japan with the endoscopic ultrasound. And so they find these little tumors. And so the minute carcinomas, the 5-year survival, now almost 20 plus years ago, was 65% 5-year survival. So again, these small tumors do have much better survival than the typical adenocarcinomas we find. This is data from Mike Goggins and Amanda Blackford that was published last year in JNCI, which shows that in the National Cancer Database, when you look at the earliest stage tumors, which is stage 1A, 1B, their 5-year survival is almost 80% plus. I mean, this is like approaching, almost breast cancer levels now. So obviously early stage cancer does have an impact on survival. But when you look at this table, you realize that the conundrum that we face in this field, which is unfortunately, these early stage tumors only comprise a minority of cases that present to a typical academic center like Sloan Kettering or MD Anderson or University of Washington. Most of the patients tend to present at a later stage disease. This is our typical profile of pancreatic cancer for stage 3s and stage 4s. So the obvious question, and I get this all the time from the audience, well, why don't we just go out and screen everybody? Should we start screening the adult general population for pancreas cancer? Let's just do CA19-9s on everyone above the age of 50. What's the folly with that? Why aren't we doing that? Next slide. So many of you may know this, but I think there's a little bit of a delay here, but if you can go to the next slide, please. Aha, here we go. So not so fast. This was the government body, so to speak, that of experts that decides or outlines the screening guidelines for different cancers is called the USPSTF, or United States Preventive Services Task Force. This body first came out almost 15 years ago with a recommendation that we should not screen the general population for pancreatic cancer. And just last year, they revisited that recommendation, and lo and behold, even 15 years later, the recommendation still stands. A grade of D, which is a failing grade, do not screen the general population because there is a moderate to high certainty that the service has no net benefit and in fact might actually cause active harm. So why are we not screening the general population for pancreatic cancer if there is contrary evidence on the other side showing that the earlier we detect this cancer, the higher are the chances that these patients may be true long-term survivors. Next slide, please. So this is the slide. This slide and the next one that I'm going to talk about really underscores the problem that we currently have in the field, which is when you talk about screening, you need to not only have a fantastic biomarker that currently doesn't exist for pancreas cancer, but you also have to take into account the population prevalence that you're screening in, because that has an impact on the number of false positives that you will go through before you detect that one true positive case. So if you look at the age-adjusted incidence rate of pancreatic cancer, it's about 15 per 100,000. So let's say that we screen 100,000 asymptomatic individuals for pancreatic cancer, and we apply a biomarker in this population that is probably the perfect biomarker, which doesn't exist at this point, but let's just make one up. It has 100% sensitivity, which means it will not miss a single case, and it has 99% specificity, which means it will find only one false positive out of all the 100 cases that it detects, okay? So it'll detect all 15 cases of 100,000, right? Because it's got 100% sensitivity. But that 1% false positive equates to 1,000 false positives out of every one case that it detects, out of every 15 cases that it detects. So now you can imagine the number of additional tests, screening, imaging studies, anxiety, the cost to the healthcare system, the potential over treatment that might happen because you find this vague shadow in the pancreas and everyone's worried and you resect it. That'll happen when you start screening everyone for a disease, which is, despite its increasing incidence, still relatively uncommon in the general population. Again, we're talking here about the general population. With the rates that we have, even if we had a perfect biomarker, which by the way doesn't currently exist, there's a lot of false positives we're going to start picking up. So it's not feasible to screen the general population. We need to enrich. Next slide. So I'm going to redo the math I did in the last slide, but now I'm going to apply it to the population, an enriched population or a higher risk population where the age-adjusted incidence is now 150. So it's about 10-fold more than the general population. Now we do the same test, 99% specific and 100% sensitive. But now because the incidence is 10 times higher, we have to only screen 10,000, not 100,000 people to get those 15 cases. But now instead of the 1,000 individuals who were false positives, we end up with 100. Now we end up in that realm of, you know, lung cancer screening and mammograms, et cetera, where there is a payoff that the healthcare system is willing to accept. 15 cases, especially of a pretty lethal disease like pancreatic cancer, 100 false positives now sounds a lot more palatable. So instead of screening the general population, what we need to do is to do surveillance in defined high-risk cohorts for pancreatic cancer. Next slide. So again, I just want to step back for a second and do a little bit of you know, terminology explanation, if you so will. When we talk about these terms in the context of screening for cancer, screening means you're testing for asymptomatic disease in the general population. You could be screening for cancer, screening for diabetes, but this is an asymptomatic general population that you're screening in. Surveillance is testing that is done in asymptomatic high-risk individuals. So you're following these patients that you've already defined as being at higher than average risk, and you're looking for disease. You know that what the disease is going to be, and you're looking for the disease. That's called surveillance. And diagnostic is unfortunately what most of us do in the clinic, where somebody comes in with the manifestations of the disease, and you're essentially testing that person for the disease that you know probably likely already exists. So instead of screening the general population, what we really need to be doing is surveillance in a defined high-risk cohort for pancreatic cancer. So next slide. This is a model that was first described by Dr. Suresh Chari, who was at that time at Mayo, and now he's at MD Anderson. Thank you. This helps a lot. I don't have to keep saying next there. So what he calls it is the DEF model of surveillance, where D stands for define, E stands for enrich, and F stands for find. And basically what he's saying is we need to define what these high-risk cohorts are so that we can enrich for them. Then we need to do surveillance, again, not screening the general population, but surveillance in that, and find where these early lesions are. So this define to enrich part of the sieve, the sequential sieves that you're doing, or think of it like an inverted funnel, if you so will. You start with the general population at the top of the funnel, and every step your funnel becomes narrower and narrower and narrower. So to get from that defining stage, which could be a clinical definition, a family history definition, a genetic definition, to the next step, which is the enrichment part, you need to have a biomarker. That biomarker has to be something that's fairly common, that can be done in an office setting. It can't be an ivory tower assay for which you need to go to Sloan Kettering or MD Anderson or University of Washington to get done. And then finally, you need to have imaging studies which will help you localize the lesion. So what are these high-risk cohorts? So I'm going to talk about 3 that we know. And again, this is not the complete pie chart. This is only a slice of the pie. But through research done over the last couple of decades, we've at least defined some of these high-risk cohorts that are at risk for pancreatic cancer. 1 is familial pancreatic cancer, 2 is pancreatic cysts, and 3 is adult onset diabetes. Next slide, please. So familial pancreatic cancer, there are, this slide lists many of the syndromes that we now know where germline mutations are associated with the risk of pancreatic cancer, and the most common one being BRCA1, BRCA2 mutation. But there are others as well that are listed here. And the reason I put some boxes around some of these names is because you can see that the risk varies tremendously. Not everyone is going to be at a very high lifetime risk. Some are several-fold higher than others and probably need more surveillance than others that are at a lower risk. And then that's also impacted by the family history that they have. So again, the reason for putting this out there is that just because you have a germline mutation doesn't mean you're going to get pancreatic cancer in your lifetime. It just places you at a higher risk. This is where you need to have a conversation with a genetic counselor or somebody who does high-risk genetics. And most academic medical centers have this sort of a service that they offer. And based on that lifetime risk calculation and family history that's layered on top of that, other risk factors, the surveillance that is done is then kind of personalized, if you so will. Okay, next slide. This is the other risk category, mucinous pancreatic cyst. Thank you. And when I introduced Dr. Kim, I said that he is the director of the cyst clinic at MD Anderson, and there are other places around the country that have such cyst clinics. So we now know that these cysts are actually risk factors for pancreatic cancer. And there's a lot of us walking around with cysts, okay? These silent incidental cysts that we don't know about. And because we do so many CT and MRI scans in our country, we're finding more and more of these cysts every year. In fact, I wrote a review a few years ago where we call this a man-made epidemic. So the picture you see, the histologic picture you see here is actually an IPMN, intraductal papillary mucinous neoplasm, that went all the way to pancreatic cancer. So these are bona fide precursors of pancreatic cancer. But the important caveat to remember is that the vast majority of cysts will actually not progress to cancer. We have about 6 million Americans who are walking around with these cysts, far more than the number of cancers we get every year. Only about 8,000 of these pancreatic cancers arise on the background of cystic lesions. So yes, they are bona fide precursors. What Dr. Kim will tell you is that he probably sees 1,000 patients every year with cysts, and he operates on maybe 25 or 30 of them. So the vast majority will never go to a pancreatic cancer. So we need to figure out who those higher risk cysts are from the ones that are indolent and can be left alone, okay? Nonetheless, as a category, this is a population that is at higher than average risk than the general population. Next. And this is the third category, which is new onset diabetes, something that has only been recognized in the last decade or so, work done by Dr. Suresh Chari again, who gave that DEF model. He was at Mayo Clinic when he made these seminal observations. And now we are actually co-leading a national effort to recruit patients with hyperglycemia and new onset diabetes based on the recognition that it represents a high-risk population for pancreatic cancer. It's very important for me to emphasize, I'm not talking about long-standing diabetes. Patients with 10 or 20-year history of diabetes have a marginally increased risk of pancreatic cancer. We're talking here about new onset diabetes or hyperglycemia, worsening hyperglycemia, where the pancreatic cancer itself is causing this glucose dysglycemia that these patients present with. And essentially the cancer hasn't yet manifested itself with other typical symptoms like jaundice or weight loss, etc. What we're instead seeing is this metabolic dysfunction. And if you go back to some of these patients who have carefully recorded glucose values for other reasons, you can start seeing this curve come up as early as 2 years. And then over time, this becomes frank diabetes. So if you look at the risk of pancreatic cancer in new onset diabetes, it's about a 6 to 8-fold higher risk than the general population. So again, an enriched population where we can potentially justify surveillance. Still not that 10-fold higher risk that I showed in my slide, but higher than the general population. So again, family history and germline mutations, new onset diabetes, mucinous cysts. Currently, at least, these are some of the known higher than average risk populations that we can do surveillance in. Next. One very quick couple of slides before I end my talk, which is many of you, especially as fellows, are involved in biomarker research or doing biomarker, publications, etc. I want to emphasize this part about why we don't have a good biomarker in pancreas cancer. Really, I mean, the CA19-9 that we used was discovered in the 80s. Why after 50 years don't we have a good biomarker? So most of the biomarker studies that are published, and there are thousands of biomarker studies that have been published every year at DDW, there are abstracts on biomarkers, are in this phase 1 and phase 2 of this 5 phases of cancer biomarker development. By the time to get to an FDA approval, you need to be at least at phase 4, phase 3 or phase 4. But most of the studies that have been described are only in phase 1 and phase 2, where you either discover a biomarker, like you do a profiling study and you find some, dysregulated microRNAs or protein or something, and you publish that paper, or you go to a collaborator and say, hey, can you send me like 100 samples that are sitting in your freezer, and you find these convenience samples, as they're called, and you do some validation studies and you publish a paper. Well, that's where most studies are. And that is not enough for it to be a clinical grade marker. It's great research study and a wonderful presentation at a meeting, but it's not going to be a clinical grade marker that can be used for decision making. Next slide. If you can click, yeah, two more. So you still need to go at least 2 more phases, phase 3 and phase 4, where you look sort of retrospectively in prospectively collected samples in patients who were asymptomatic when the sample was collected and went on to develop the disease of interest, in this case, pancreas cancer. And there are biorepositories like that, like UK Biobank and the PLCO, which is sort of the final test that really rigorously establishes the value of a biomarker, which is a phase 4 study where you use your biomarker for decision making. So for example, you would take your biomarker and you would take a cohort of patients that have germline mutations or pancreatic cysts, and you would use your biomarker to make clinical decisions. This person needs to go to surgery. This person doesn't need to go to surgery, and show that your biomarker works. That kind of high rigor is what would be required to actually make it a clinical grade biomarker. And 99.9% of biomarkers are not there. So that's why we are still using CA19-9. Next. Next slide, please. So I want to end with this slide, which is, many of you are trainees or future generation. I just want to emphasize that there are tremendous opportunities in early detection research. There are a lot of things that are going on in the area of therapeutics, and rightfully so. But I think the one place where we have an opportunity to really make a tremendous impact and lead to true long-term cures in patients is in the area of early detection. It is one of the top priorities that the National Cancer Institute has recognized in its roadmap for progress in pancreatic cancer. The Department of Defense now has a dedicated pancreatic cancer research track that it funds. It's called the Pancreatic Cancer Research Program. And this year in the programmatic priorities, early detection was the #1 bullet point. So this RFA is going to come out later in this summer. Look out for it. There is a partnership track where junior PIs or even advanced fellows can apply with a more senior mentor. So there are tremendous opportunities for early detection. And again, the impact of what you can do in this field would be truly indelible. So thank you. And I really appreciate the opportunity to speak with you. All right.
Terrific. Thank you so much, Anirban. That was wonderful, and a really, really nice overview of what's happening in the space. So we're going to now initiate the panel discussion, and just to remind us all, so we have Dr. Maitra, Dr. Chiorean, and Dr. Kim, and myself, and it's open to the audience. We'd be delighted to hear your questions in the either Q&A, or you have an opportunity to unmask your audio and articulate it directly. So we'll look forward to those. And maybe I'll just start the discussion here. And Anirban, I'm going to ask you if you could just give us a quick recap on what CancerSeek is and what the methylation assays are looking for, where they are in development, and what you see happening in the next couple of years.
Great question. And so when I said that there's no biomarker right now, I didn't mean to say that there was not a lot of activity going on. There's tremendous activity going on. And there's a lot of activity going on from companies that obviously have the bandwidth to do these large scale phase 3, phase 4 studies, especially the phase 4 studies, and which often academic labs cannot do. Academic labs probably have to stop at the phase 2 and then sort of pass the baton to these companies. So there are several companies in this space. And again, I'm not, I don't have any skin in the game in any of these, but there's Grail, there's a CancerSeek, which is, the company is called Thrive Earlier Detection, but now it's been brought over by Exact Sciences. So it's an Exact Sciences company. And so CancerSeek was a panel that was first described by Bert Vogelstein and others from Johns Hopkins. It uses a ctDNA-based mutational assay, plus a protein signature of a panel of proteins. And the advantage of using the proteins is that it allows a little bit better discrimination of the site of the cancer where this is coming from. So cancer-seq is ctDNA for mutations plus proteins. GRAIL has a methylation-based assay where it's looking for promoter methylation patterns in cancer, again, in the circulating free DNA. And then there are other companies that have come into this. There are companies that are looking at another form of epigenetic alteration called 5-hydroxymethylation. So there's a company called Blue Star Genomics that got a accelerated sort of development pathway for pancreatic cancer test, and they're using 5-HMC signature plus proteins. So all of these tests in the blood that are being developed by companies like Exact Sciences and GRAIL, they come under the category of what we call multi-cancer early detection, or MCED tests. And these MCED tests are now being used because the idea here is that you're not just trying to detect one cancer. So you're not just using CA19-9 or CA125 or CEA. You're trying to detect many cancers across the population. The idea being basically that this will become kind of like a metabolite panel you do for an annual checkup. You come in and you do this test that will screen for lung, for breast, for colon, for pancreas, for biliary, whatever. And if something is abnormal, then you go and get the relevant test done. Now, this has not yet been proven, this data. I mean, this looks great, but most of the studies have been done in a diagnostic setting where you have diagnostic samples. There's some early data to show that this might catch some cancers in a pre-diagnostic surveillance setting, like in mammography populations, et cetera. But the real sort of, are you catching these important cancers like pancreatic or lung in a truly asymptomatic population? One, and two, is that correlating to a stage shift and improvement in survival? That data has not yet been established, and those are going on. For example, GRAIL. Again, no academic lab could do this. GRAIL is actually partnering with the National Health Service in England, and they're doing this Galleri trial, which is going to use their platform to screen patients through the National Health Service. And so I think that in the next few years, we'll have that kind of data and the definitive proof whether these multi-cancer early detection tests truly translate into early detection, stage shift, and the final sort of, the holy grail, as I say, improvement in survival.
Thank you. Yeah, that's a terrific summary of what's happening. Again, very, very exciting space. And I think for Michael and Gabby and myself, the part of it that we see where I think there's a real potential to intervene is the subset in terms of genetics, but also the group of people with adult onset diabetes. I mean, that's a very real population. Probably 40% of people will have a prodromal history of, an increasing HbA1c or mild glucose elevation. And if we got 3 years head start on this, that could really stage shift this disease.
Absolutely.
So it's again very exciting to see that focus in practice. So maybe I'll shift slightly and ask Michael if you could just give us a quick primer on CIS and the challenges of CIS and how you look at them in terms of prediction modeling for malignancy and what would be, relevant to our audience.
Yeah, thank you for the opportunity to talk about it. I think about 2/3 of my practice is pancreatic cysts, so it's something that I think most people in the pancreas field are inundated with, because we know that only about 2% of all cysts will turn into kind of the malignant pathway into pancreatic cancer, all comers, but that risk is proportional to the size of the cyst. So what I tell patients is anything 1 centimeter or lower is small, a 2 centimeter cyst is medium, and a 3 centimeter greater is large. And a 3 centimeter or greater has a cumulative incidence of malignancy of about 15% over the next 12 years. So that's not a small amount. That's a significant proportion of that patient population. So we don't really start biopsying anything until around 3 centimeters or looking, considering resection. Everything below that, we just kind of watch anywhere from every 1 to 2 years, or sometimes 6 months if there are some worrisome radiographic features. But we don't really get too excited about them unless they start to change. So if the main pancreatic duct gets dilated, if patients have symptoms, pancreatitis, CA19-9 increases, any of those things are kind of red flags. And we follow those patients much more closely, get EUS, map the pancreas, look for nodules. Those are the ones that basically declare themselves to be high risk. Otherwise, we just watch with serial CT scans. The cysts above 3 centimeters, given that 15% or more risk of malignant transformation, usually every 6 months it's a scan, MRI alternating with CT. We've had over the last 5-6 years, I've had about maybe a handful of patients who within 6 months or 8 months have turned from a cyst to a solid mass. I mean, it just blows my mind that happens, but we see it. Those are the outliers. Those are the ones I don't think Dr. Maitra's, those are the ones that Dr. Maitra's approaches might really help to find and to really kind of mark those people, and because we can't find those, we can't resolve those patients with current techniques. But overall, I think these patients need to be followed indefinitely, and we do a lot of that because we know that the risk of cancer never seems to go lower. We don't know what happens after 12, 15 years, but it doesn't seem to get lower. It's either plateaus or goes up over time.
Thank you.
Thanks, Mike. I have a question actually for Eileen or Gabby, whoever wants to answer it, which is, where do you think we are going in terms of the minimal residual disease space in pancreas? I mean, that's obviously something that the colon folks have done amazing work in and doing, but we really haven't done a lot in that space. And I know trials are just starting, and it kind of fuses our topics a little bit together because we're looking for early detection of recurrence here, but where do you think the activity is in that space?
Sure. Gabby.
I'm going to try to take a little stab at this. So one thing that I was going to bring up, of course, is this area of circulating tumor DNA, and the fact that if I think about colorectal cancer, I would say that the ctDNA status after surgery, or even people that undergo metastasectomy, is an area of very avid research, I would say, and it seems to really predict outcomes. In pancreas cancer, there are several initiatives, especially from the Alliance Group, to actually include ctDNA testing in patients with localized disease and potentially even influence treatment choices or change treatments depending on the status of the ctDNA. But I think that, you could argue that you could develop a beautiful study comparing neoadjuvant versus adjuvant therapy based on ctDNA. I'm just giving an example. So I think that we wish we had better treatments. We wish that if we, let's say, had FOLFIRINOX, and at the end of the FOLFIRINOX, we still had ctDNA or positive CA19-9s, let's say, we would have a magic bullet to counteract the resistance. We have gemcitabine nab-paclitaxel, of course, but unfortunately, we don't have a large plethora of options in pancreas cancer. But I think that this area is definitely incipient, and we should be looking at it more carefully.
Yeah, and I think I'll add to that. I agree. I think ctDNA has many potential applications in pancreas cancer. One of the challenges, though, is the ability to detect, and especially in early stage disease where the disease is treated, and the limitations of our current technology, I think, is still a challenge. But our hope is in the next few years that we'll have, validation that this is predictive. And I think in many malignancies, ctDNA positivity predicts almost 100% chance of future disease identification in the MRD or minimal residual disease setting. In pancreas cancer, we suspect that's true, but we don't have a lot of data to say that yet. We'll see some data at ASCO in metastatic disease showing that it's approximate an early biomarker of response. And so it might be something that we could use for screening multiple compounds, right, in the metastatic space, just getting an early signal of whether we should continue looking at them or whether we really need to move on. But I think the other application that you're alluding to, Anirban, is vaccines and some of the KRAS targeting strategies. And there are several trials now that have just been activated in the last year and even more recently that are trying to see if we can begin to both immunize people with minimal residual disease and capitalize on this early detection of subradiologic active disease that we're not seeing. So it's very, very exciting. I think we have a lot of work to do, but just the fact that we're thinking about this now in pancreas cancer, I think is a big step. Yeah, so Anirban, you're on mute there, and I know we had a couple of questions from the audience. I think Anirban, you may have
I've answered them both. I've typed in the answers. I do think the one on the pediatric chronic pancreatitis, I want to make sure that I want to, and if Dr. Abu El-Hajja wants to address the question a little bit with more expertise than I did. I just talked about the PRS as one setting, but obviously pediatric pancreatitis is a huge spectrum, and she may address this later in her session as well. So I want to make sure that we have that opportunity to have that addressed. The other question on non-secretors is a very good question, and obviously the ctDNA will overcome that, but there are also other proteins that people have used in the non-secretor patients, and that is a real problem with CA19-9, that there's a fraction of patients who simply don't make it, and so we'll miss them if we just use CA19-9.
Yeah, I think in terms of serum detection, yes, but I think a lot of those probably have tumor expression.
That's right.
Yeah, there are some sort of drugs that are in the clinic now targeting CA19-9, which is also very, very exciting. So maybe Gabby, I'll just put you on the spot here and just give us, a rundown of why immunotherapy hasn't had the same luck so far in pancreas cancer as in other diseases, and what you think are the most promising strategies for integrating immunotherapy, because I guess we're still all hopeful that we can make this happen.
Yeah, thank you, Eileen, for the question. So I think that one area where we thought could be, part of the reason is the cold tumor microenvironment, the fact that we don't have, even if there are immune cells, they are oftentimes immune suppressive cells in the tumors. Many times the immune cells are far from the actually cancer cells, more in the stroma, and therefore we need to find ways of enabling them to reach the cancer cells in order to see them and in order to react against them. We talked also about the prevalence of neoantigens, the tumor mutational burden, which in pancreatic cancer, even if we say, well, there are so many different mutations, somehow they don't trigger the same level of immunogenicity. And again, the tumor mutational burden in pancreas cancer is so much lower comparing with other tumors where we do actually see benefit from immune therapies. So I think there are very many factors. Could it be the vascularity, the perfusion into the tumor? We oftentimes, when we do this kind of clinical trial preclinically, actually we look at the perfusion levels and do CD31 stains to see is there vascularity, because if the immune cells can reach inside the tumors by having a well-perfused tumor, obviously it's going to be very hard for immune therapies to get in there. Almost the same reason why chemotherapies don't work quite as good. So I think there are very many factors and very many compartments that really create this immune suppressive stroma that's really surrounding the cancer cells. So I think we have tried, the standard agents, the PD-1s, the CTLA-4s, et cetera. We need to look at other immune cells, the MDSCs, the macrophages, and try to maybe look at different strategies and combinations for sure. We know that one single agent is not going to do the trick. Potentially even find better biomarkers of who the patients that may benefit from immunotherapies really are. There is an inkling that maybe the basal subtype of pancreatic cancer may be a better subtype that benefits from immune therapeutics. So I think there are very many factors, Eileen.
Yeah, thank you very much. I agree. It's very complex, right? And multiple factors likely contributed to this, but I guess there's still that optimism that we will get to the fundamentals, and once we understand, hopefully be able to leverage better with combination strategies.
I just wanted to bring up the topic of the microbiota, the fact that we found microbes, including Fusobacterium, inside the pancreas. So potentially, again, the microbiota profile of a tumor could also be a strategy to guide us who would be the tumors that may be benefiting from immune therapeutics. We know that this biomarker, so to speak, may correlate with benefit in melanomas and other tumor types.
Yeah, and if I can chime in here, a little bit of chest thumping here for our own Florencia McAllister here at MD Anderson, who's doing some really amazing work with the microbiome. What she's trying to do is one, seeing if there is a profile of microbiota that actually correlates with response to immunotherapy, and then alter the microbiome in those who are non-responders through fecal microbiome transplants. You know, now the poop pill that gastroenterologists have used in the past for everything from immunotherapy toxicity to GVHD, now can we use that same approach to revert immunotherapy refractoriness to one of responder. And so there's a lot of very interesting work going on. Certainly just last month, there were 2 back-to-back science papers showing that this has now been done in the context of melanoma. Obviously, pancreas cancer remains that fortress that we haven't yet sort of been able to get through. So if FMT works, altering the microbiome, that would be really a game changer in this disease. And then Florencia is doing some really exciting preclinical work trying to understand, what equates with a responder profile versus non-responder profile. So yeah, there's a lot of excitement going on. I think in the context of immunotherapy, one thing that we have learned, and again, Eileen and Gabby, I don't want to misspeak you other oncologists on this call, but I think it's fair to say that we need to start combining them with cytotoxics. I mean, I think that the use of the cytotoxic appears to be important, either to release antigens, to prime T cells, and then sort of use the immunotherapy to sort of rev up the T cell activity, et cetera. But I mean, if you look at the combat data or Bob von der Heidt's PRINCE trial, the few successes we have been the ones where we've had a combination of a cytotoxic backbone. Is that a fair statement?
Yeah, we're slow learners in oncology, but I agree with you. I do think there's something to chemoimmunotherapy, and we have, and Gabby and I and others are part of multiple trials where we're sort of looking at this, and these are intense combinations though, and they are, they're hard for patients over time. And I think one strategy that we're kind of beginning to get some traction around is intense combinations initially, and then de-intensifying therapy. And for example, learning if we can utilize maintenance immunotherapy combinations. And this will build off the POLO study that Gabby said we now have a precedent for maintenance treatment in at least a genomically selected subset, but this could arguably be attractive to a greater subset. And, time will tell. And I think there are many, many different combinations being evaluated.
I just wanted to reiterate the idea of the early stage, that oftentimes, we study all new agents in metastatic disease.
I agree.
Clearly, the metastatic sites may be niches, especially those liver metastases that may be more resistant to immune therapeutics. And I think that we need to utilize our neoadjuvant approaches, apropos to the neoadjuvant strategies even in resectable disease, to utilize combination immunotherapeutics, even with chemos or radiation or other means, and learn about what really works in early stage, and not wait and apply everything in metastatic disease.
So I know we're just drawing right to 12:45, and I might ask Michael just one more question as we maybe close out the session. Just if you could speak to us, Michael, what you think are the key kind of innovations that are coming in surgical management of pancreas cancer, and maybe platform studies, neoadjuvant, just to give us a quick rundown.
Yeah, I think it's all going to, and it pains me to say it, as kind of a surgeon, but and I think the field will be driven by the advances in the drugs. I think there's locally advanced is locally advanced. The only way we're gonna tip the scales on that is better drugs, tumor shrinkage, and if a tumor is encasing the SMA, there's not much around that. Patients get chemo, so that's going to be driven by new drugs and perhaps immunotherapy. And I think tumor neoantigens and antibodies directed against KRAS and mutant P53 are all going to be combined in various ways down the road, and hopefully will kind of result in that regression of tumor for all of them, but specifically in that borderline locally advanced. We just need to find ways to get those tumors to shrink off the vasculature so we can resect them. For the potentially resectable, that is, I look forward to the kind of trials with FOLFIRINOX you alluded to, and the more modern chemotherapies. That is an area that I think will be very interesting. And that might change how things are done in terms of, I think about, last number I saw was about maybe 30% of the country is giving neoadjuvant therapy for pancreas cancer. And for all the reasons we kind of discussed, I think, most patients would fit into that neoadjuvant space, and to see how that hopefully kind of raises the 30%, current number to much higher. I think we'll see, translation to improved therapies or into survival. But I think it's a very, very interesting space. It's going to be drugs. It's going to be driven by the immunotherapy, the more efficacious systemic chemotherapies. That's where I think it's not going to be surgery that helps people. It's going to be the systemic therapies.
Great. Well, thank you so much. And remains for me just to thank all the panel, Anirban, Maitra, Gabby, Chiorean, and Michael Kim, and myself. We hope you've enjoyed the pancreas cancer session. And I think next is a break, and then for the case presentations. Thank you all.
Thank you.
Thank you.